Good afternoon, everyone. Here we are in February, and the weather's kind of moderate. At least I hope it is where you are. I always like to remind people that when the weather is cold, and I know it is in some places, to be sure and cover your arms and legs, even if you don't feel the temperature. Your body will still react to it, and you can still get frostbite and all those wonderful things. Just like in the summer, you don't want to overheat. In the wintertime, you don't want to be too cold. So be sure and dress appropriately, no matter what your sensation level are. We have some questions today, and so I'm really excited to get to those questions. I'm going to see if there's anything which have something to say or something to add or something to ask, please feel free. So today I'm going to start with a question that had come in, which is a pretty big question, and I think it's applicable to everyone. And it's about going home for the first time after rehabilitation. Now, I know a lot of people listening have been home for quite a while, so you might have some experience with this. But if you think about back about that time when you were going home, and this person who's written in has been is a quadriplegic, and they've been uh, in alternative placement for a year and a half, and now they're making the change to going home, and so they're looking for advice. So if anybody has any advice, be sure and type it in, because oh my goodness, this is so huge. And I think from my experience is a lot of this has to do with expectations. And when you get home for the first time, it's like, oh, I'm going to go home. Everything's going to be great. Everything's going to be wonderful. Um, I'll be in my own environment. I'm going to be so happy when I get there. And then when people get home, they see right away it's not quite as simple as it is. Now, working in rehabilitation for quite a number of years, I can tell you that people in rehabilitation facilities have worked very diligently to try to make the home transition easier. And so they prepare you, they teach you how to catheterize yourself, how to do your own bowel program, or if you're not able to do these things, they'll teach a family member how to do these things, how to monitor your skin. And those are the big things to think about, the three big things to think about when you first get home, because there's so much to think about. If you can just narrow it down to bowel, bladder, skin, and just concentrate on that until you get your routine and what you're doing, how you're going to do it. So I know in rehabilitation facilities, things are set up, or long-term care facilities, things are set up for wheelchairs. Um, Products are delivered, uh, you know, when you need them. Somebody will bring your catheter to you. Somebody will come tell you it's time to do your bowel program. Somebody will be helping, assisting to do these things with you. When you get home, you might be totally on your own, and the supplies will be different. Instead of having that catheter kit where you have the kit, you have the catheter, you have your gloves, you have the drapes, you have the cleansing supplies, it's all in one kit. And when you're finished, you get to close it all up and throw it all away. It's very simple, very easy. Somebody brings it to you. Maybe you have a stash in your room. When you get home, it's different. The supplies come differently. You have a box of catheters. You have a tube of lubricant instead of a little package. You have just all these. You might not have a drainage device to put the urine in. You might be expected to catheterize and drain your urine into the toilet. So there are all these different supplies that, it's just different. And you have to organize. Setting up your bathroom is a huge operation so that you have everything all together when you need it. If you're going to go out of your house, you'll need to have a little go bag, as they say in the military. I got to have my go bag ready. So you will need to have your bag packed with your catheter supplies, whatever you might need to do while you're out in public. You never want to go out in case something happens. The car breaks down, the van breaks down, or something. You get delayed and it's catheterization time. What are you going to do? When you're in the hospital or in a long-term care facility, there is a routine of times when things are done. And when you get home, you might think, In the facility, I always catheterized at 6 a.m. Somebody came and woke me up, helped me get ready for the day, and then I would go have breakfast. And so I always catheterized at 6 a.m. But now I'm at home and I don't want to get up at 6 a.m. to catheterize. So if you want to get up and catheterize at a different time, that's fine, but just know your catheterization schedule, because if you're no longer catheterizing at 6 a.m., but suppose you were catheterized at midnight, which gives you a 6 hour window. If you change your time to 8 a.m. in the morning, now you've got an 8 hour window, and that's too long. So you have to back up the midnight catheterization to 2 a.m. So, you can schedule it how you do your catheterizations. So if you catheterizations are done from between 4 and 6 hours, depending on the individual. So if you're a 4 hour catheterizer, set your schedule of how you want it to be for every 4 hours. If you're a 5 hour catheterizer, set it. If you're a 6 hour catheterizer, set it that way. Some people will be able to wait a little bit longer at night after they've emptied their bladder for the last time. So if they've had their feet up for a while and they're in bed and they've drained their bladder, sometimes they can go a little bit longer at night. Maybe they cath every 4 in the daytime, but 6 at night. So know what your schedule is so that you can plan around that. Again, focus on that bladder, focus on your bowel routine. If you have been in a facility and you've always had your bowel program in bed, not the first day, but after you're home a while, ask your healthcare professional if you can get a commode and start catheterizing or start doing your bowel program using the commode, because that's so much easier to if you can get the commode, if you can get into a bathroom, if you can get to the place where the toilet is and you can put that commode over the toilet, there's like practically no cleanup for somebody to do or for you to do, because you can just flush it away. And so that makes it a lot easier, but that would be a long-term plan. Don't think about that the very first day you're at home, but think about how you can manage your bowel at home. And then think about how you're going to do your pressure releases, because there's not going to be anybody to remind you. That's going to be on your watch. And you might want to get a watch that has a button that will alarm you every 15 minutes, 10 or 15 minutes to do your pressure releases. That's helpful to get started. You don't have to have one. You can take cues from your environment. And, like I say, when people are watching TV in the evening time and a commercial comes on, they come on about every 10 minutes. If you're not watching subscription TV, if you're watching TV with commercials, they come on about every 10 minutes. So do a pressure release. That's a cue that you can get from your environment. So there's lots of little tricks that you can do, but focus on those three things. Now, when you get home, you might not have a ramp to get in and out of the house. Hopefully, in your planning, the ramp is there and you're ready to go. The ramp should be for every inch of height, you need a foot of ramp. So it goes for 1 inch of height. So if you have a step that's 6 inches, then you need 6 feet of ramp for that 1 inch to be safe. And you need some sides on the ramp so you don't happen to roll off of it or something. So they need to be safe. So, think about how you're going to get in and out of the house if you don't have the ramp. And say a ambulance, or as they call them, cabulances. They're people that you can hire with wheelchair facilitating vans that will bring you home. They will help you get into the house. But if you don't have a ramp, you're not going to be able to get back out again unless you have somebody who can help you. So that's an important feature to have ready when you get home. You can have somebody build a ramp that's sturdy. You can buy them that are aluminum that can be installed pretty quickly. They're kind of expensive. Ramps are expensive either way. So we're not talking about a cheap little operation here. It's a little bit of effort to get that done, but that's one of the things you want to do. If you do not have a way in and out of your house, or if you use electricity, like for mechanical ventilation or to recharge your wheelchair, when you get home or before you come home, you'll want to call not the emergency number, but call the regular police number, call the fire station, call the paramedics. Paramedics and fire stations usually one call, and call the electric company to let them know that you have a person who has special needs in your house. So if you don't have a ramp to get in and out, and there's some kind of emergency at your house, let the fire station, the policemen know that you are in there and you're maybe not going to be able to just run out of the house if there's some kind of an emergency situation. Or let the power company know if you need to have your electrical system turned on right away. These people will tag your house so they'll know what's going on there. So especially if you're on mechanical ventilation or if you're requiring a power chair to plug in so that you can recharge it. Otherwise, you can't get around if the battery's drained. So they will tag your house and know that you need special assistance, and they will keep that in their records. So that's very helpful. Even if you've been home for a while, if you haven't done that, be sure and do that because that's really important, especially with this wild weather that we've been having with these storms and floods and all this kind of stuff. It's very important to let emergency personnel know that you will need special help if something happens. Now, hopefully, nothing will happen. I mean, that's the goal, right? But, we can't really be, account for if a huge storm comes and floods everything. And, this has been happening more and more. So now another part of this question was, and making the transition easier for the spouse. And the best thing that you can do in that regard is to be sure and have open communication with your spouse. And it goes both ways because sometimes people will say, "Oh, I don't know. I don't know about. I don't want to say something. I don't want to hurt your feelings. Um, like your bowel program's really stinking up the house. So, get some air freshener or the potpourri or, whatever. But be able to be very frank with each other and be able to laugh. Yeah, you're right. This is really a problem. So let's figure out what we can do about it. And then always being gracious to each other. And that's a very important thing. Now, we all get frustrated. We all get angry. We all have, moments when we're just like, Hey, I'm done with this." So if you need a timeout, take a timeout. Be sure that if your spouse is your care provider, be sure that they have some time to themselves. Now, your spouse at first is going to be um, probably more attentive than as time goes on because they're going to be worried. Am I doing this right? And do you need anything? How's it going? Are you okay? So it's going to take some time to learn your rhythms together. But if you have good communication, open communication, if you can laugh about different things, the Kessler Institute has some videotapes that talk about how to be a caregiver. And so those are very helpful because they don't say this is how to catheterize. They don't tell you this is how to do a bowel program. That should already be learned in the facility. But they do say things like they help caregivers learn, like, I need to have this when I ask for a cup of water. I need to have the cup of water placed in one certain place on my tray. Otherwise, I can't reach it. And if you don't know that, if you don't have that experience of either working with people who have mobility issues or being a person with a mobility issue, they're not going to be automatically thinking, "Oh, well, of course, that's so obvious now that you've said it." So just keeping those lines of communication opening, but that's a good review that at the Kessler Institute to listen to those videotapes of being a caregiver because it really helps with communication. Another thing that would be helpful is to look into the mentoring program. The Reeve Foundation has a fabulous mentoring program. They're people who have spinal cord injury or other neurological problems, and they're also people who are caregivers to people. So you might have a mentor, your spouse could have a mentor, and these are people that go through classes, they know what they're talking about, they have this personal experience. They try to match you up by characteristics. So, like if you're a spouse, they'll match you up with a spouse. If you're a male spouse, they'll try to match you up with a male spouse, or if you're female, they'll try to match you up. So they look at different characteristics to try to find some commonalities so that, maybe you're in the same age. Although I was with the Houston group not too long ago from the Reeve Foundation, the mentors from the Houston group. Shout out to my Houston buddies. What a wonderful group. These guys were living life and they were living large. And I would imagine any one of them would be very helpful. There was a woman mentor there. Well, I'm sure there was one more than one, but this one woman I met, and she was mentoring. She was a mother with children, but she was mentoring a woman that was in high school, and the two of them just got along about with just like gangbusters. They became very best friends because the younger woman was transitioning into adulthood and being independent, and this other woman had lived it. And so they just found this common bond. So you just know who you're going to hook up with and how it's going to work out. But and if it doesn't work out, you can always say, you can call the supervisor of the mentors and say, this just isn't really working out with for me, and that's okay. But generally, it works out pretty well. So that is another thing. Peter has written in home commode suggests absorbent pads or those chucks beneath the commode at bedside to catch accidents, which is a very good tidbit of information, because some people will you have to learn your body. Some people will have their suppository or their mini enema, and they'll take that while they're laying down, and then they wait the time because they know how quickly that's going to work in their body. And then they'll transfer into the commode chair so that they're not putting that pressure on their rectum, because the commode chair has an open hole in it so that the stool will pass into the toilet or into a pan that's underneath the stool. So you don't want to sit on the commode chair a lengthy period of time, because all the weight of your body is now being pressed through that hole that is in the commode chair. So you can have problems with rectal prolapse and different things. So get to know how your bowel program works so that you can time it out as needed to be. Now, you won't know this the first day you get home. And the reason why I say maybe it worked a certain way when you were in the facility, you've been there for a year and a half, and maybe you were just regulated right as rain. When you get home, there's going to be a certain amount of tension of the change, just simply from the change. Anxiety, how's this going to be? We might not even realize it, but everybody has tension or anxiety about different things that affects your bowels. When you get home, you're going to be having that home cooking, and it's going to be good because that's what you were used to. And it's just going to be so good. And you're going to think, oh gosh, yeah, I'm liking this. But your diet's going to be different than it was in an institution of any sort. So your bowels might not work as speedy as they did before, or they might work faster than they did before. So if you can get those first three things done, bowel, bladder, skin, focus on that, and then just let the rest happen. And as you go through and you get a little more comfortable, then start adding on to different things of now, I think I would like to go outside. I think I'd like to go out to a restaurant, or I think I would like to go do something that I did before. There are all different kinds of things to be doing. And so maybe the first day is not the day to go do that. Now, equipment sometimes can be a problem, and this is a slippery slope. If you have a hospital bed that's coming, some insurances will not pay for it to be delivered even a day early. It won't come until the day that you arrive, and then they have to set it up. So here you are at home, say you got home in the morning or in the early afternoon, and your bed still isn't there. Somebody has to come and deliver it and set it up. It might be time to be getting a pressure change, and you can't get into your bed, or you need to rest, or, any of 1,000 different things. So that can be quite a challenge, but sometimes nowadays they're being a little more kind and delivering them a day early. So I don't know if that's going to be an issue for you, but there's always something, some complication that will come up. So be ready for it because we don't know what it's going to be. We don't know how to plan for it, but something for sure will come up. So you just have to roll with it and just keep moving ahead and see how it goes. You also will be given a huge book, a discharge manual that will have all the information about you in it, your medicine, how to do a bowel program, how to catheterize. There's also a book, a great book about going home and being at home from the Reeve Foundation. And it's just like the greatest book. It's it's a big book. You can download it for free. You can get it on hard copy if you want a hard copy. It's a big book, but it has everything that you could possibly need to know. Now, that doesn't mean to read all these books the day you get home, but have them on as a reference, especially that Reeve book, because it'll give you a lot of information to get about how to get out and about, how to do different things. It goes from the basic things, bowel, bladder, skin, all the way into all different kinds of things about going out in the world. So that is a really good resource, but don't be overwhelmed with it. You don't have to read it the first day you're home. Just look up the subject matter as you go. If you have a moment, flip through it and say, hey, I didn't think of this. Maybe I would like to do this particular thing. And then you'll have the opportunity to look all that up. So that's a lot of talking about that, but the basic uh, situation is be prepared for anything because anything can happen. So, but it will all turn out fine. Just take it slow, take it easy. You don't have to be a miracle worker at the very first day. Just let it happen. Okay, so here's another question we have. Uh, a woman writes in that her adult son got paralyzed in September of 22. He has a huge heterotrophic ossification growing out of his hip. And the last surgeon he saw said he could take the bony out, but he would have to take the hip out too, which means he'll never be able to rehab because the growth he's never had rehab. Now his leg is like stone, can barely get into a wheelchair. I'd like to know what other individuals have done. And this 75-year-old single mother, and he also has some pressure injury. So first of all, let's talk about the heterotrophic ossification. This is something that happens to people who have spinal cord injury. It can also happen to people with head injury and stroke. So it can happen to people really with any kind of neurological injury. And what happens is the new bone formation, because bone's like skin, it's constantly turning over cells. And so the bone marrow gets a little hyperactive and the bone grows outside of the bone and grows into the muscle. It usually happens at a joint. That's why it's at the hip. It can happen in the shoulder, it can happen in the elbow, it can happen in the knee, it happens a lot in the hip. But it can happen anywhere in any joint. You can get it in your little pinky finger joint too. There's medications that you can take for this. Durigenate is one of the medicines, but there are several medications that are now available that you can take to help reduce the bone formation into the muscle. And so you can take it before surgery, or you can just take it as a treatment. If it starts to happen and you catch it early enough, you can start taking it, will help dissolve it. When the bone in the muscle, growing into the muscle, gets significant enough, it's exactly what this woman says is happening. The joint becomes so that it becomes immobile, so it's difficult to bend. So it's good if you're doing your range of motion that you see that, if things are becoming stiff, it could be from spasms, it could be from a lot of things. It could be from contracture, but it could also be from this bone growth. So once you feel a little, you can't move a joint as much as you could move it before, it's important to report that right away so they can see and determine what's going on and get treatment for that. So when it gets to a certain point, yes, you do have to have it surgically removed, and they will have to take out some of the muscle, but it won't stop you from rehabilitation while it's there and they can't move it. Then you can't move the legs. So that you can't do that much with that leg, but you can still provide therapy to the other side of the leg. But um, so sometimes they have to take out some of the muscle because it's intertwined, it's woven in there. So sometimes you have to take, but you don't have to take out the whole muscle. You just have to take out some of the pieces to loosen it up in there. And then for this seems to be a bad case, so it's really heavily in the joint, and they'll have to take a joint out, but they can put a replacement joint in there. So that would be an option. I don't know if that's an option for your son's particular situation, but be sure and check about it because there was thinking in the past about people who had paralysis, be it from head injury, stroke, spinal cord injury. If a limb was paralyzed and there was some kind of issue with that limb, like heterotrophic ossification, they call it HO for short, or if there was a pressure injury or circulatory problem, they'd say, well, you're not using that limb, we'll just take it off. You don't need it anyway, and it will be easier, less weight for you to transfer. This is not the thinking now. That is outdated thinking. The thinking now is everybody has potential. So you want to be sure and check into that because an artificial limb, if that an artificial hip could be placed where that hip is, and that would help him in his long-term rehabilitation. So be sure and check into that. Now, I don't know that that will be the case for him, but that will be an important question. And check with a couple of doctors because if one says, "Oh no," get a second opinion and see because that would be an option for your son. Now, it says he also has bed wounds, so now that might preclude the surgery on the HO until the wounds have healed up. So that would be an important thing to get treatment for those wounds and try to get those healed up. Another thing that they might do is they might do a wound closing surgery at the same time that they do the hip if it's in the same location. Now that would be a rarity because of infection. You don't want that in that wound. There could be infection that you don't know is there, or that when you open all that up, if that infection would travel to the bone, then you've got infection in the bone, and then it's really hard to treat that. It's treatable with antibiotics, but it just makes everything more and more complicated. So it could be that they might work on closing the wounds, giving you the medication to reduce the HO, and then do the surgery for removal of the HO at a later time. Now, people say, "Oh, well, let's just have the surgery for the wound closure." Well, that leaves a scar, and then the tissue is forever more fragile because scars are not elastic. Even when the wound heals up, there'll still be a scar and it's not elastic. So once you have a wound, your skin is more fragile. So, there's a lot of complications here, but it is possible. So, it'll probably be heal the wounds, take the medication, and then have the surgery after that, is what I would think would be the plan. Now, that might not work out for your son. They might choose to do something different. And that's an okay thing if they have a different plan and they're prepared for those different issues, like I was talking about, infection and that sort of thing. So I hope that that works out for him. Here's another question, and I think maybe this one is on my list as well. I'm curious about cerebral palsy being connected to SCI due to pain and numbness and tingling, also gait issues, even incontinence concern from a post-spinal nerve injury that causes incontinence. Can they all be connected? Of course they can. They're both neurological diseases. So, we often talk about neurological disease. Mostly I talk about brain injury and stroke and spinal cord injury, as well as other diseases. So there's the trauma group and there's disease group. If you have neurological injury, it's equal. Sometimes people think because we call it spinal cord injury or brain injury that all we're dealing with is trauma, but that's not true. And I am very conscientious of this. It includes diseases. It doesn't matter what the source is. it it's the same treatment. It doesn't matter the cause. It's still going to be the same treatments or approximately the same kinds of treatments. There might be medications for some diseases or, different kinds of treatments, but basically the rehabilitation is pretty much basically the same kind of thing. So, can cerebral palsy and spinal cord injury? Yes, you can have issues injury from cerebral palsy of mechanism of it's still a neurological disease. So you can have the same outcomes even though the causes are different. But I know a lot of people will say, oh, that you're just talking about trauma. I am never just talking about trauma. And I can tell you exactly why, because my husband had neurological disease. And so I'm very conscientious of being sure to include both groups. Now, sometimes we talk and we talk about trauma, but trauma can be, or injury can be from trauma or disease. So it's both. We encompass all of those things. Head injury, spinal cord injury, we encompass it all. So yes, all those things can be, and it would be pretty much the same treatments. There would be some differentiations with the cerebral palsy because you would have still some sensation. So there might be some difference in something like, say, the electrical stimulation part of spinal cord injury or a brain injury. So there will be different things, but that's what rehabilitation is. It's all tailored to the individual needs and the specific needs of a person. So somebody's written in from Uganda, and is it possible to get your services to reach Africa? Well, all of the Reeve information is online. So everything is available to everyone, no matter where you're from. And there's a lot of the information is translated into different languages. And so it's pretty accessible to anyone over the internet. So that is an option. Um, Somebody writes in they have severe stenosis in their neck, they're paraplegic at T5 for 40 years. What is the long-term prognosis? Well, actually, for people with spinal cord injury, their lifespan is the same as for people without spinal cord injury, especially in the thoracic level. Now, when you get into the ventilatory dependency, it's a little bit shorter, but not all in all that much. But there are differences depending on the level. But so what's the life expectancy? It's going to be just the same as for anybody else. Now, for the spinal stenosis, sometimes that gets worse, and sometimes they'll do surgery to release that tightness in the area where that stenosis is, because you said that was up in your neck. So sometimes they will do surgery, but a lot of people have stenosis and they do some range of motion exercises, or they do some stretching exercises to kind of open up that space in there around there. If it's in the disc area, if it's in the vertebral body, that's bone. So that's, if it gets too bad, you would have to have surgery in that particular area. But long-term progress is just the same as for anybody else. Reusing catheters can't afford. Any comments? Well, nowadays we don't recommend reusing catheters. Years ago, everybody reused their red rubber catheter, boiled it, and would reuse it for about a month or so, but that's really not recommended anymore. If you're having trouble getting catheters, talk to your healthcare physician, because there's probably going to be some program to help you get those. If you're on Medicaid, they will assist you in getting them. If you're on private insurance, they should be supplying enough catheters for you. So talk to your healthcare physician. Maybe he needs to up the number of catheters that you're using. So be sure and talk to your healthcare provider, because you should be allotted with private insurance or with Medicaid enough catheters to get a clean one, sterile one every single time. So somebody writes in that they just found out they have a cyst on their hip joint that's 4 millimeters. So I'm not sure what the question is about that, but I would suggest that you talk to your healthcare professional to see if that needs to be drained or if they'll will give you antibiotics. Sometimes they don't want to open up the cyst, they give you antibiotics to reduce the cyst. And so because once you've opened up the skin, you've opened up a conduit, even under sterile conditions, where an infection could get in there and have even more. It might be a cyst that has normal body fluid in, that's not an infection at all, or it could be a closed infection, so they might give you antibiotics for that. Um, Contact information so I can get proper treatment, Nurse Linda. Well, you can always write to me. If you go to the Christopher Reeve webpage, there's a big blue button there and it says Ask Nurse Linda. And that's exactly how you get in contact with me. So I'll be looking forward to seeing you. I've got your name now written in my head. So I'll be looking forward to talking to you and we'll communicate and see what's going on. Now let's see. Oh, somebody has written in here about using hyperbaric oxygen for their spinal cord injury, 4 years. Now, there are some programs that offer this, some rehabilitation programs that offer this. There's been some research that has said that there's some benefit from this. It's not conclusive. And as checking just this morning to be sure, it is not FDA approved. Although when I checked, I got a lot of ads for FDA approved hyperbaric treatment for spinal cord injury. So there are some that are local, like you can have like a small covering on a particular place on your body, like for wound healing or putting oxygen into the wound at a higher rate than is in the air that we're breathing. But using the actual chamber like you do when you take that deep dive and you come up with the bends if you've been diving in the ocean or something. And I did have a gentleman who had a head injury and a spinal cord injury. Well, he had both, but he actually was diving in Hawaii and came up too fast and got the bends, and they put him in the hyperbaric oxygen chamber, and he had some little dots in his MRI. You could see little air bubbles in his spine, so he became paraplegic. But one day I went in there and he had gotten it was getting ready for the day and he had exactly half his face shaved and exactly the other half was not. And I'm like, well, did I interrupt you? Were you in the middle of shave? No, I'm all finished. Well, we found he had neglect of that one side, and so he also had these little bubbles in his brain. So he had both his brain and his spine injured. So that makes kind of an interesting thing, but he had hyperbaric chamber to reduce those bubbles in his brain and spine from coming up too fast, but it couldn't take it completely away. But now that's kind of a bit unusual because most people don't have that kind of diving accident. But there is a lot of hype out there about having hyperbaric. As I say, there are some rehabilitation facilities that are offering it. And as I will say to you, the results of studies are mixed. I have known patients that have gone and they've said, oh, it feels great. I love it. I think I've got improvement. I've had the same number of people who've gone to it and said, didn't do a thing for me. It was a waste of my time. So, the jury's out on that one. There is not a yes or no answer, but keep following the science and see how that is working. Um, so there's a person who wrote in that they've lost function in their uh, legs, bladder, and bowels, and they're getting treatment at Kessler, which is a great place in New Jersey. I spoke about the Kessler Institute earlier for those caregiver classes, and that's a great place. So that's going to be their cutting edge. So you're going to be getting really good treatment there. Now, this is a very interesting question. It comes up quite a bit, and I'm sure a lot of people are wondering, where can I get weighed? I'm in a wheelchair, I can't stand. I've called a lot of places and no one can help me. This is so frustrating. So usually what we recommend is to call your local hospital. They will have a wheelchair scale. Call the nursing department. You know, the operator's going to say, no, we don't do that. You have to get to somebody in authority. So call the director of nursing or the vice president of nursing. You'll talk to her secretary. You'll say, this is my situation. Can I just come in and use a scale to get weighed? And generally they will say yes. Long-term care facilities also have wheelchair scales, and generally they will say yes. Now, sometimes they don't want to take on the liability, and they've got a lot of ifs and ands, so you have to kind of keep at it. But if you just call and, ask whoever answered the phone, they're going to tell you no. So you have to work your way up the chain until you get someplace. Talk to your healthcare professional. They might know someplace, or they might have the pull to call the director of nursing and say, I need this patient weighed. I'm going to send them over. And sometimes that will, if they're on the staff at that hospital, sometimes you have to use people in authority to help you. Now, other things that people have done, which now this is way out there. I knew one guy who went to one of those truck weighing stations and got weighed there. Okay, that is really thinking outside the box. And somebody else had to take the wheelchair over later to see how much the wheelchair and whatever he was sitting in. Now, once you have that wheelchair weighed and you know what the weight is, as long as you aren't adding extra things, you have to weigh exactly the same every single time. But sometimes I knew one person who did that. I've known people who have gone to like a butcher shop when they're weighing big bulk products at the butcher shop, at the grocery store, at the Walmart, um, at places that accept huge uh, weight weighted items. Like where trucks go in and they drop off a load. Sometimes there's a scale there because they'll measure it not by the items, but by the weight of the load. So sometimes you can get weighed there. Again, these are way out of the box kind of thinking, but any place where there's any kind of huge scale, um, I'm trying to think where else. There's somebody else told me about some other place. I can't think of it off my head. Maybe they'll write in and refresh my memory. But there's all different kinds of places that have really huge scales. So if you know any kind of like trucking area, oh, I know where it was. It was at the recycler. Because at the recycle place, if you go to a metal recycler, you pull your car, your vehicle, your truck, your van, whatever, you pull it up to a scale, they weigh it with your items in there, then you empty it out, and then you go back and you weigh your vehicle again. And that's how they reimburse you for how much weight of metal that you've brought to them. So that was an interesting thing. So you could actually go there in your van or in your car and get weighed, and then get out of your van and car in your wheelchair, and then just weigh your van and your car, and that will give you the idea. I thought that was a very clever. People get clever ideas more and more, and it's just wonderful. So here's a question about um, a person. We've got a lot of urine questions here, so I'm going to try to put these together. Here's a person that's having bladder stones, which is clogging up their catheter, and they're super painful. They're drinking lots of water and taking cranberry pills. What else can I do besides change the catheter more often? Well, the best thing to do is try to reduce the number of stones that are being produced. And there's medications. So if you take alpha blockers, they help open up the ureters and the urethra so that the stones can come out more quickly. Allopurinol is one of several drugs that can be taken to help reduce the formation of stones. And there was another thing. There's some medicines that can help you can help you reduce the stones, and there's several different medications for that. So check with your healthcare professional, because you want to take the medication for the cause of your stones. And also, which is often overlooked, is movement. So do your pressure releases. If you can do side to side, tilt your wheelchair back and forth, lift up and down, because the more movement you can provide, range of motion to the legs, because if you're moving the legs, that's moving the abdomen. Anything you can do, rolling side to side in the bed, rolling back and forth, because that's all going to shake up your bladder and help keep those stones from clumping together. So movement is also often overlooked. So be sure and do your range of motion, and that will be very helpful as well. How long can a woman go using an indwelling catheter? I'm going on 48 years, and she's had some luck, but she's wondering if a suprapubic would make changes easier. Well, now this is very interesting um, because an indwelling catheter is so for 48 years, that's pretty long. You can have an indwelling catheter forever. Most of the time, we like to do the intermittent catheterization because there's less risk of an infection. Now there's some more controversy where there's some studies that are coming out that say that the indwelling catheter doesn't cause that much infection. So that's new science. So we have to see how that's going on. But if you've been doing this for 48 years, you're succeeding. Now, would a suprapubic work make changes easier? Yes, and the incidence of infection between an indwelling catheter and a suprapubic are not really that much different. Also, for women, there is a third option, and for men as well. But women usually do it because catheterization, because of anatomy, is intermittent catheterization is so difficult because of anatomy. Men have more access, so it's just easier for men. But there's a thing called the mitral fan off, and it started out in pediatrics. And they take an appendix or piece of the bowel, and they attach it to the inside of your belly button, and then to the top of the bladder. And so you can do intermittent catheterization by putting the catheter through your belly button, and then it goes into your bladder. And a lot of women are using that option as well. But actually, um, the suprapubic, if you're having stones like this other person, the suprapubic is the more desirable if you're having a lot of stones. Now, there's an article that came out about in 2013, so it's 10 years old now, but it was kind of interesting because what they found was people who had suprapubics had more stones than people who had the traditional indwelling catheter, but the stones were easier to treat and they were smaller and easier to get out. So, it's kind of an individual thing. So it's kind of an interesting thing about the suprapubics. They make it easier for some things. A lot of men get suprapubics, and a lot of people who have AD, they automatically do a suprapubic to control for the AD. So it's not that uncommon of a procedure. It is surgery, but it's not that drastic of a surgery. So it's oh, the other question was suprapubic catheter versus a Foley catheter in men. And that is of course an option. It's same for men as for women as to which you prefer. The infection rate's not that much different, and so, but you might also consider the mitral fan off because then you can do the intermittent instead of having a catheter the whole time. Here's a question about self-care, and they say it's getting more difficult to practice good self-care as COVID has created such a chaos in our life, and it's still out there. People kind of are dismissing it now because we're not being as cautious as we used to be. But there's a lot of viruses that are coming out, and lots more treatments that are coming out too. So there's the RSV that's people get. It used to be just in children, now older people and people with mobility issues are more susceptible. Norovirus is sweeping through our country right now. I saw in the news yesterday that 13.9% of people in our country have had norovirus this winter, which gives you vomiting and diarrhea. It goes through the GI system. There's no treatment for it. You just wait a while and you get over it. So So self-care is really, really difficult, and learning to take care of yourself and being bold enough to take care of yourself is very important. So, for instance, if you feel like you are in an environment where you need to wear a mask, if somebody's coughing and hacking around, be sure and wear a mask. Now, there's a lot of controversy. Are masks effective? Are they not effective? Well, it's better than nothing. Let's put it that way. So, will it be helpful? Quite I still wear my mask on occasion, depending on where I am and what I'm doing, or if I go someplace and I find that somebody is sitting around me or they're coughing and hacking around, and then they'll always say, "Oh no, it's just allergies." Well, you're still coughing. That's spewing out water droplets into the world. So, if you feel more comfortable in doing that sort of thing, then do it. Washing your hands is the number one thing. Social distancing is important. You don't want people coming up close to you. You don't want people touching you, um, randomly touching you. Sometimes people will want to shake hands, or they'll come up if you can't shake hands, and they'll, pat your hand. So, just say, just please don't touch my skin, or whatever you feel like comfortable in doing. But washing your hands or having your caretaker wash your hands. If you have any hand movement at all, if you, I am so bad at this, rub my eyes, rub my nose, constantly touching my face. I've really reduced that a lot over COVID, but I find I'm getting right back into my old habits. So that self care is really important. You really want to pay attention to taking care of yourself, because that is going to be critical. Okay, I would like to know if there's any treatment for sensitivity due to incomplete spinal cord, because I have wounds on my left leg for 4 years, never closed completely, and I realize it's related to my paralysis, but no healthcare professional has been able to treat it effectively. Sometimes those wounds take forever. It could be due to lack of circulation. So if you can put your leg up when you're seated, if you have an elevating footrest, which makes it really hard to get through a doorway, which really makes it hard to get through a hallway. But if you have an elevated footrest, that you can put your leg up so that it will help the blood return up to your heart. When you're in bed, if you put your feet up on pillows higher than your heart, that helps your circulation as well. If you're still having trouble with the wounds after this length of time, which is not necessarily that uncommon, you might want to try something like a wound vac, to help draw out some of the debris that might be in those wounds. That might not be appropriate if it's from a circulatory problem. You might want to try doing range of motion with your legs so that they're exercising to get that circulation going in your legs. Check with your healthcare professional first, because you don't want to do any more damage, or you don't want to make it worse. But I'm just surmising that that's probably what the problem is. And so if you are seeing your regular healthcare professional, ask for a referral to a wound care specialist, because they have all kinds of tricks and options, and they will be able to help you get that cleaned up. Here's a person that has a traumatic spinal cord injury. Um, they've made tremendous progress in assisted walking, and their dad had Parkinson's. I'm afraid to tell my father, because I'm afraid to get a diagnosis with Parkinson's, and MDs won't be as motivated to help me. Your thoughts? I think that just assuming that you have Parkinson's because your father did is putting too big of a burden on yourself, because you may not get it just because your father had it. If you're thinking you have symptoms of Parkinson's disease, and you're thinking maybe that's why you're kind of worrying about that, it's the perfect time to talk to your MD so they can give you treatment, and they would be happy to. It won't make your treatment less. It'll make them more anxious to help you maintain the function that you have. So that if you have Parkinson's disease, there's medications that you can take, that can't make it go away, but it can help with some of the symptoms. And so they would be more than anxious if, in fact, you do have Parkinson's disease, they would be more than anxious to help provide that treatment for you so that you can maintain your function. Healthcare providers want you to maintain the function. That is their goal in life, is to help you. And if you find out that you don't have Parkinson's, then good for you. It's one less thing you have to worry about. Okay, here's another person that they've been paraplegic for 30 years. They're in the process of evaluating mobile commode seats. They saw the self-propelled commode, which goes over the toilet, can be used for the shower. Is anyone use this device? And my alternative option is to use the travel version, which neither my occupational therapist nor vendors has experience with. I'm curious if anyone has ever used the RAS mobile commode chair that folds up, or alternative self-propelled commode chairs. Well, I'll tell you, there are many brands of self-propelled commode chairs. And in my experience, no matter what commode chair you have, you want to have a good brake system on it, especially if it's a mobile chair. Now, there are some that just have that little tiny brake lock on the wheel. Those don't really support as you're transferring. Those can come undone, or they'll roll a little bit. They're not as tight as those that have the lever on the sides that actually lift the commode up a tiny little bit so that the wheel is not touching the ground. Those are more secure, and my experience is it's the brake that's really important, especially if the chair is mobile. So check out the brake. Um, a person who's post-injury MRI shows good surgery and hardware, but they're having some myomalacia at the C5. Can you explain this more? Neural states due to the degree of damage at the time of injury. Any possible treatment, or should we follow up with a future MRI? Well, you want to keep following up with that just to see if your healthcare professional recommends it. Sometimes they're exactly right. Sometimes the full of extent of injury doesn't show up instantly because there's a lot of things that happen within the body on the cellular level. There's inflammation, there's swelling. Once the swelling goes down, then the injury can change in its look on the MRI. So it might be something just to keep tabs on. You can request MRIs and follow along with that. Usually, spinal cord injury does not get worse. If you're having worsening symptoms, then something else is going on, like a syrinx or fluid collection in there. It's pretty rare, so don't, oh my gosh. But spinal cord injury, once the level has been set, so like within, and the level's not really set for like 6 months. So for like 6 months to a year out, once you have that level, you might see some improvement. You might go down a little bit as some of that inflation includes. You might go down a level, but generally it does not go up. So that's an important thing to remember. So you should be okay. And with that, we are exactly at the top of the hour. So I thank you all. It's been a wonderful discussion today. And I really appreciate you coming, and come back on March 13th at 2 p.m. Central Time. We're having Dr. Susan Newman, who's a nurse like me, a PhD prepared, a certified rehabilitation nurse, with a group, Brian Denny, who is a peer mentor in South Carolina. He's the head of the program there, and our own Bill Cawley from the Reeve Foundation, who's the head of the mentor program here at the Reeve Foundation. And we're going to have a discussion about peer mentoring. So please be sure and tune into that. If you can't tune in, it's always available on the YouTube channel. So I'm kind of excited about that upcoming. And again, at the end of the month, last Wednesday of the month at 2 p.m. Central, we have our Nurse Linda webinar. So I look forward to seeing you again at both of those events. Thank you.